Hello and welcome to the checkup. I'm Alex Kasich, Senior Operations Reporter for Modern Healthcare. Tufts Medicine is a Burlington, Massachusetts-based health system that includes Lowell General Hospital, Melrose Wakefield Hospital, Tufts Medical Center, the Home Health Foundation, and a network of more than 2,000 integrated physicians. Tufts joined forces with the Home Health Foundation in 2018 to expand its reach and create one of the largest home health and hospice providers in the region. In 2021, its physician networks combined to form a clinically integrated network. I have the privilege of speaking with Tufts Medicine President and CEO Michael Dandorph to learn about how its diverse business model and clinical integration helped the organization weather the COVID-19 pandemic. Thanks for joining me, Michael.
Nice to see you, Alex.
So I wanted to start with an overview of the different assets that make up Tufts Medicine, so we can better understand the scope of organization and its operations. So could you please provide us with some bit of a background there?
Sure. The system was formed back in 2014, really with this vision of trying to create a marriage between academic medicine and community healthcare, and really try to do something different. Very, very focused on value-based care, finding ways to continue to push a great experience for patients, great quality outcomes, but at a lower price point in a very expensive Boston market.
Understood. So I'm curious, you have these different assets from the home health division to clinically integrated network of physicians. How did that business model help you weather the COVID-19 pandemic?
Sure. Well, a number of things. And I'll go back to when I started here. I actually arrived at Tufts Medicine, then called Wellforce, in late January of 2020. And about 6 weeks in, we had to become prepared to handle the COVID-19 patients that were about to hit our doors. And we made a decision that we were going to curtail some of our elective services to be ready for that. And what I would say is, we quickly mobilized an organization that was historically very much a holding company. Everybody did their own thing. It was a typical system in name only at the time. And there was collaborations, but it was basically collaborations when it made sense. And anybody within the system had veto authority to say, you know what, we're going to just do it our way. When COVID hit, we were starting a process to transition from this holding company mindset to an operating company. It was something that the board really wanted us to focus on and pay more attention to. And that was part of my recruitment. So I had started a process after being here for about a month of really trying to change that culture and start just over time. I figured it was going to take us a couple of years to start to get everybody aligned around a common mission and vision. COVID hit, and immediately we needed to figure out how do we work together in a different way. We were short of ventilators. We were short of PPE. We had to make decisions that really affected the entire system from a cash management point of view, from an employee policy point of view, work from home, standing up telemedicine. And we quickly formed teams from across the system to start to think about how do we mobilize the resources that we do have to make sure that we were focused on two things: saving as many lives as we possibly can and keeping our people as safe as we can. And that level of focus just sort of forced people to come together, or compelled people to come together, really. It happened pretty naturally. And from there, we just started to build an integration plan around this mindset that we were stronger together, we were working better together, and we had different assets across the system, as you said, that we could be leveraging. Home care was an enormous advantage for us because we were able to keep people that didn't need to come into the hospital out of the hospital. That taught us a lot about how do we integrate home care and our clinically integrated network and our hospital network.
I'm curious on the home health side, how does that shape operations going forward for you? We've seen more acute services moving into the home. Remote monitoring is such a bigger component of chronic care management as well as other issues and diseases. So, does has the scope of how you view how you'll deliver care in the future change as a result of that home health component that's bigger, and as well as like how you had more of an introduction, a pretty sudden one at that, and how to mobilize that quickly.
Yes. Yeah. Yes and yes. So we learned a lot about what would it take to do more acute care in the home. And it's certainly an area that we're investing in now and want to scale in a meaningful way. We piloted quickly a program called Mobile Integrated Health, where instead of somebody coming into our emergency department that was under our care, we would actually deploy a team of paramedics that would actually do that emergency care visit in their home, and frequently avoided the need for that individual to come into the hospital. Because we know once they're in the hospital, the ED and the busy EDs are trying to get them moved through, either discharged or up into a bed. And now we have a process that actually that discharge goes to home, and that's connected in our electronic medical record, which we just stood up in April.
So does that alleviate some issues around capacity for your most acute care patients in the inpatient setting? And from a staffing perspective too, I imagine, you're able to mobilize and leverage different caregivers in the home setting, and that virtual component as well. So I imagine it's helped as a release valve in certain respects.
I'd say it did. And then the fall of 2021, maybe late summer into the fall, this great recession or great resignation started to hit us, right? And we started to deal with some staffing shortages. And we've been thinking about, okay, how do we make sure that we have the right staff in the right places? But we've also been challenged with having to increase the number of contract labor staff that we have, and managing through that. So I wouldn't say we've realized the promise yet of that, in all honesty. But we are working diligently in terms of making sure that we don't lose sight of the fact of the future of care. For certain acute episodes of care needs will be in the home and won't need to come into a hospital. And that will open up capacity for us to be more efficient in the patients that actually do need to be in the hospital.
Is that hinge on any kind of reimbursement end? I know there's a Medicare waiver, for those subset of beneficiaries, but I'm curious, is scale impeded on the reimbursement front on a broader scale?
A little bit. So
Yeah.
the state really mandated parity early on to make sure that we could use technology and telehealth as well as services within the home. And I think what we're doing now is also working with the private payers, right? We don't expect to get paid the same amount for the care that's done in the home, but it's much more intensive than a home care visit, right? So
Mhm.
the payers and the employers and the consumers should really benefit from this, as well as us, and that's an opportunity for us to expand our reach as a health system.
One of the many ripple effects we can go into, but one that comes to mind is, the shutdown of elective non-urgent procedures. And from what I understand, Tufts has about 400,000 lives under value-based contracts. So I imagine having that diversity in terms of your payer mix and those reimbursement models helped sustain Tufts as a organization through these intermittent shutdowns over the past 2 years of electives.
Yeah, well, we're working through that, right? So we have value-based care agreements. I wouldn't say that we're as far as being capitated for those lives. So from a cash flow point of view, we actually saw a dip in our volume and the resultant dip in our financials that the CARES Act and other state support has helped us with to muddle through. But in the fall of 2021, we went close to 5 months without providing elective services. That, coupled with the increase in staffing, has been a challenge, and we're working our way through how do we recover from those financial times.
And I'm curious too. I'm watching the Massachusetts Health Policy Commission meetings pretty often, and one of the common themes of those board meetings are how to best utilize different hospitals in the state. So, like your organization, like so many others, are anchored by an academic institution,
Right.
but a big focus of the policy commission is trying to ensure that the lower acuity care is getting to the most appropriate setting in some of those community hospitals. How do you keep that in mind? You know, you have all this fixed infrastructure when it comes to your academic institution. How do you ensure that patients are going to the right setting at the right time?
Yep. Well, it's part of the culture at Tufts Medical Center, our academic medical center. And when I got here, one of the early things that we developed as part of our vision was how do we think about the academic medical center as a distributed model? That can we help to elevate the programs that are in the community hospitals to keep people out of the academic medical center? So Tufts Medical Center is a relatively small academic medical center, about 450 beds. It's not a 1,000-bed academic center where we're trying to keep those beds full. We're actually trying to make sure that that's a resource in the system for care that can't be provided closer to home. And what we're really committed to, and actually this is where the HPC and Tufts Medicine are very, very aligned in the sense of, hey, we want care at the lowest cost. We really do want to double click down on being more value-based care driven, being more risk driven, and moving into more capitated models of care. And some of that experience throughout the pandemic, but even before the pandemic, in terms of our clinically integrated network and our physicians working together, we think we're well prepared to actually sort of mobilize that, lower the cost of care for people of the Commonwealth and the employers of the Commonwealth overall, by thinking about how that care gets managed and the site of care as well, keeping quality very high and the experience very high.
I imagine too some of these joint ventures and affiliations you're making can help in that effort. Where Melrose Wakefield proposed, which has hospital campuses in Medford and Melrose, proposed a joint venture with Shields Healthcare Group. The JV would own and operate a licensed clinic to provide certain imaging services to patients in the Melrose Wakefield service area. So I'm curious, what are the drivers behind those strategic affiliations, and how do they aid your organization in some of the themes that we've been talking about?
Yeah, one of the things that we have to think about, right, is there's a lot to do to transform healthcare, and we have the bandwidth to do an awful lot. But what we're looking at is are there partners that we can engage with that would allow us to accelerate and mobilize quicker than if we were to do it all ourselves? And do they bring resources that we would otherwise have to build in order to execute on those things? So Shields is a good example because we do some imaging joint ventures with them where they've brought some capital to the table. It's allowed us to expand our capacity from an imaging perspective, keep costs down, but keep it integrated within our system. We've done the same thing with ambulatory surgery centers in joint ventures with our physician practices, where Shields owns a piece of that, the physicians own a piece of that, and we own a piece of that, and they've worked really well. They align incentives, they're keeping care in low-cost settings, and we can provide a great care experience to our patients. I mean, it's a sort of triple win in a lot of ways.
Sure. And, one of the things from what I understand is that Tufts is trying to simplify the healthcare processes through some of these initiatives to make care more affordable, to make the experience both on the patient end and the employee end more streamlined. Could you tell us more about those efforts and how you're setting about to achieve them?
Yeah, so we, as I said, when I first got here, one of the important things that I wanted to do was, if we were going to integrate and we were going to, many systems get together and they share a common name, but they're not really integrated and not thinking about clinical care processes in an integrated way across all those settings of care. And I felt like if we were going to do that, and the board wanted to, that we needed to anchor to something, that we were really a shared vision, a shared purpose of what we were trying to do. And we started to anchor on this concept that what we can deliver is a frictionless care experience. We're not there yet. There's going to be investments that need to be made, but could we commit that every decision we make is going to move us forward in that vision, with that goal in mind overall? So we were on different EMRs. We came together and implemented Epic across the system on April 2nd. All of our hospitals, all of our employed physician practices, a number of our private practices, our home care company, all on one platform now. We put that platform through a joint venture with or a relationship with Amazon Web Services and AWS. And we put not only Epic, but our entire ecosystem is going to be up in the cloud. So we have a little over 100 applications that will sit in the cloud and interface with one another in a more frictionless way. Our goal is, if we're going to deliver a frictionless experience to the consumer and really treat the patient like a consumer, and we've used the word consumer in a deliberate way, if we're going to do that, we have to create a frictionless experience for the care team. We have to make it easier for people to deliver the consumer experience they want to deliver and the patient experience that they want to deliver. And that's sort of our strategy right now, is how do we bring that together? And if you think about frictionless, right, it includes great quality, a great experience. It empowers the patient or the consumer more to have some control over when they schedule things and where they go, what's convenient for them. It includes equity, and the inequities that exist in some of our communities create a lot of friction for those communities, for the family members, and ultimately for the patients and individuals that we serve. So we really think about frictionless on a number of different levels, and thinking about how do we use digital to start to accelerate that overall. And I'd say we're not done figuring out where there's partnerships that can help us get there quicker.
Understood. Well, we'll keep a watch out for some of those partnerships. In the meantime, Michael, hey, thank you so much for taking the time to sit and share with us your experience and expertise.
Great. Thanks, Alex. It was great talking to you.
All right. Thank you for tuning in. Please join us for the next checkup.